Thank you for joining us for today's training, Addressing Co-occurring Disorders in Nursing Facilities, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and it is my pleasure to oversee the delivery of mental health and substance use disorder training and education to nursing facilities nationally at no cost to the nursing facility. And now, I am happy to introduce our presenter for today, Mr. Mark Sanders. Mark is an international speaker, trainer, and consultant in the behavioral health field, whose work has reached thousands throughout the United States, Europe, Canada, Caribbean, and the British Islands. Mark is the author of 5 behavioral health books and has 2 stories published in the New York Times best-selling book series, Chicken Soup for the Soul. Mark has been a certified addictions counselor for 34 years and is the co-founder of the Serenity Academy of Chicago, the only recovery high school in Illinois. I'll now turn it over to Mark to begin the presentation.
And thank you so very much, Nikki, and good afternoon, everyone. And 4 years ago, I was flying in from Arizona to Chicago, where I live. And on the plane next to me was a man who had earned 6 Purple Hearts. How do you earn a Purple Heart? I'm glad you asked. Bravery. He was about 95 years old, a World War II veteran. In other words, for 3.5 hours on this flight, I'm sitting next to the bravest human being I ever met in my life. And at one point, he said, "Mark, what do you do?" I said, "Well, I'm a social worker. I give speeches. I talk to people who help others for a living, counselors and therapists and people who work in nursing facilities." And he told me to tell you, thank you for your service. Thank you so very much for your service. The world cannot compensate you enough for the important work that you do. Our topic today is co-occurring disorders, which is the intersection of addiction and mental illness. And I've been at this for 41 years, the recovery business. People often ask me, how have you given 41 years of your life to this work? And the answer is, I collect stories, recovery stories, and they keep me inspired. So I'll share with you 2 of them. There was a woman whose addiction landed her in prison. And the first day she showed up at prison, the corrections officer, the guard, gave her a roll of toilet paper. She ran out in one day, said to the guard, "I'm out of toilet paper." The guard said, "That was supposed to last a whole week. You have to make do. This is not Ritz-Carlton Hotel. This is prison." "Let me repeat it," he said. "This is not the Ritz-Carlton Hotel. This is prison." 2 years ago, I was at a conference in Washington, D.C. The conference was held at the Ritz-Carlton Hotel. And she was the keynote speaker. Told the story of her recovery. She'd been in recovery for 10 years, right? Successful business owner. I collect recovery stories. The second story is in honor of National Hispanic Heritage Month. It's about my friend Juan. Juan is Puerto Rican. He grew up on the northwest side of Chicago in a Puerto Rican neighborhood named Humboldt Park. When Juan was a little boy, he went to his father and said, "Poppy, I'm going to become the next Roberto Clemente." I don't know if you know Roberto Clemente, but he's the greatest right fielder who ever played baseball. You see, me and Juan shared a baseball hero. Roberto Clemente is my all-time baseball hero. It wasn't just because he was a great baseball player. He was a humanitarian. During the offseason, Roberto Clemente would leave Pittsburgh, fly to Puerto Rico, and build houses for people, repair houses for people who had lost their homes during hurricanes. I'd like to believe that if Roberto Clemente were alive today, he'd be in Puerto Rico right now, building houses for people and repairing houses for people who lost their home during the hurricane. Anyway, my friend Juan wound up heroin addicted, homeless, sleeping outside on the very baseball diamond where he had the dreams of becoming the next Roberto Clemente. He went to drug treatment and he got a job. He was in early recovery. And he said early in his recovery, the state of Illinois caught up to him and started garnishing his paycheck for back money he owed the state. He said, "Mark, the state of Illinois was taking so much money from my paycheck. I felt like I was homeless again because I was back eating in soup kitchens." One day he was so fed up on the sides of his paycheck, he was headed outside to relapse. I was going to get high, he said. And he ran into a man that he'd gone to treatment with. And the man said, don't get high. Call the state, set up a meeting, tell them your story. Don't ask for anything. Juan set up a meeting with the state of Illinois. He said, listen, I'm in recovery. I have a job, but I feel like I'm homeless. So much money is being garnished out of my paycheck. I'm back eating in soup kitchens. The state employee said, you were homeless? Juan said, yes, I was homeless. He said, when we served those wage garnishment papers to that address, whose address was that? Juan said, it was my mother's address. And the worker said, you didn't live there? I said, no. He said, well, then that's an illegal serve. He tore up the paperwork in front of Juan, threw it in the garbage, and said, you owe the state of Illinois nothing. My friend Juan places more people in sober housing than anyone else in the state of Illinois. He said, people have helped me, and now I'm helping other people. You know, the best part of that story is that when he entered recovery, both of his sons entered recovery too. Native Americans asked me to share with you that what you do to help a person with their recovery will impact their family across 7 generations. 7 generations. Now both of his sons are in recovery. What you do matters. So let me share with you some good news before we start going through the slides. Are you sitting down? Okay, good. Okay. The good news, according to the research, is that 75% of individuals who have addictions will eventually get into recovery. If it doesn't end their life first, eventually they will get into recovery. Now, these are based on 50 years of research. Usually when we look at research on recovery, they're 1 and 2 year studies. But longitudinal stories, looking at an addictions career across 50 years, 75% will resolve this. If I can give you some examples. Some of you are familiar, you might remember with a baseball player named Darryl Strawberry. In the mid-1980s, Darryl Strawberry played on a team known as the New York Mets. He was also addicted to crack cocaine. So he would routinely leave Mets games and go into Brooklyn and the Bronx and use crack cocaine. He's now in long-term recovery. Some of you know of an actor named Robert Downey Jr. As a matter of fact, somebody posted on Facebook his arrest records from the 1990s. He was like the poster child of active addiction. Now actor Robert Downey Jr. is in long-term recovery. And some of you who've been around for a few 24 hours, you remember a singer named Elton John with the big glasses, right? Elton John that sung the song Benny and the Jets and Your Song. The 70s and 80s. Singer Elton John used every drug under the sun. This year he celebrates 33 years of recovery. And one of his acts in recovery was to reach out to a rapper from Detroit, Michigan, who lived in a trailer park on a street known as 8 Mile. Eminem said, I want to help you stop using drugs. This year, Eminem celebrates 12 years of recovery. There's Lamar Odom, the left-handed basketball player that won championships with Kobe Bryant and the Lakers. He married a Kardashian. He almost overdosed and died. He's now in recovery. Let me bring it closer to home. The date was May 29th. The year was 1986. I'm giving my first speech ever. The room where I'm giving this speech, there's a knock on the door. Is there a Mark Sanders here? There's an urgent phone call. Take it now. My mother was on the other end of the line. My mother was crying hysterically. She told me that my dad had just died in a closet at work. He was smoking a drug of his choice, cocaine. They found my father dead in the closet. Next to my father was a cocaine pipe. A month later, my Uncle Isaac went in front of a judge one more time, pleaded for the judge to give him drug treatment instead of incarceration. The judge said, why should we give you a drug treatment? You've been committing crimes since you were 10 years old. My uncle said, Your Honor, every crime I ever committed can be explained by untreated addiction. So they put my Uncle Isaac in treatment. He was the first member of our family to enter treatment. We now count 30 members of our family who are in recovery. It started with one man. Native Americans asked me to share with you that what you do to help someone with their recovery today will impact their family across 7 generations. Are you sitting down? Because I have more good news for you. Okay. So in nursing facilities, you work with your fair share of individuals who have mental illness as well. Some have a combination of mental illness and addiction, which we call co-occurring disorders. The research is in. Long-term studies indicate that the residents that you work with that have mental illness, when you look at them over the long term, 1/3 of them will remit completely. You would never know that they had that mental illness. I bet you right now as we speak that you couldn't walk through your nursing facility and tell which patients ever had schizophrenia and which ones didn't. Because 1/3 will remit completely. You'd never know they had the condition. 1/3 makes some progress according to the research. 1/3 remits completely. 1/3 makes some progress. And then 1/3 makes no progress or they stay about the same. But the majority get better. So if what I'm saying is true, then why would we want to address co-occurring conditions? Because you can cut down on years of suffering. Some people's pathway of recovery is called drift, where they get sick and tired of being sick and tired. They're 67 years old. They're tired of using drugs and chasing a high. They stop. But by then, they have so many medical complications, they live 2 more years. We want to cut down on years of suffering. That's why we do this work. So here are your objectives. By the time we're done, you'll be able to articulate 7 ways that substance use disorders and mental illness interact with each other for residents with co-occurring disorders. You'll be able to explain the difference between 3 types of co-occurring disorders treatment. You'll be able to provide services and make referrals based upon the resident's level of readiness to change. And you'll be able to support residents with co-occurring disorders. Thank you for being with us today. So by definition, co-occurring disorders, 2 coexisting disorders, independent of each other, but yet interacting with each other. Each is characterized by denial, ambivalence, and is treatable. When mental illness and substance use disorders coexist, both should be considered primary, and treatment for both disorders is needed. Let us chat. Would you find your chat feature? I have a question for you. If you have a resident that has mental illness and they also have a substance use disorder, an addiction, which do you treat first? Mental illness or the addiction? Would you put your response in chat? Which do you treat first? And Nikki, I'll check in with you to see what people are putting in chat. Which do you treat first?
They are co-treatment, both addiction, both. Let's see.
Yeah, this is a wise group because
Mental illness.
right now there were more people that said both. So let me respond to my own question. When you're working with a resident that has a mental illness and a substance use disorder, the only place you can start is where they let you start. Some will let you start by addressing mental illness. Some will let you start by addressing the addiction. You start, but they let you start. Because if you try to start anywhere else, you get a bunch of resistance. Now, let me weigh in on something else. And the people who taught me to be a drug counselor 41 years ago, when I first started, they're rolling over in their grave right now as I speak. So we always wonder, which came first, the chicken or the egg? Mental illness or the substance use disorder? And 41 years in, I now believe that for so many residents that you work with that have a co-occurring disorder, and both disorders, I now believe that most of the time, mental illness comes first. And the symptoms often show up in childhood and adolescence, but parents don't notice it, grandparents don't notice it, and the teacher doesn't notice it for 2 reasons. One, the symptoms are often subtle. He looks kind of sad. She's kind of anxious. She isolates from other children. The symptoms are often subtle, number one. And number two, they don't notice it because of the stigma. Sometimes there's a 10 to 15-year gap between when mental health symptoms first appear and when the family gets help for it. But by then, the young person might already be medicating those symptoms with the use of alcohol and other drugs. Let's go back up to the definition. Two coexisting disorders, independent of each other, but yet interacting with each other. Let's talk about how the two interact. I have a short list for you. I'm glad you asked. All right. First off, they overlap at the rate of 50%. So half of those residents you work with that have addiction have mental illness and vice versa. I think it's higher. Just don't have time to prove. So how do they interact with each other? Marijuana can be used to medicate the psychotic symptoms of, say, schizophrenia or other types of psychotic disorder. Is it me, or have you noticed too, in your neighborhood, they now have CBD oil facilities, places where you can get CBD oil, CBD tablets, legal marijuana, right? These shops are operating, opening all over the country. Here's what they've done in Europe. They've done some studies in Europe that indicate that individuals in Europe who have schizophrenia, that CBD, which is the cannabinoid inside of marijuana, when extrapolated from marijuana and put in medicine form, does a better job at managing psychotic symptoms. And what do we mean by psychotic symptoms, right? Hallucinations. And there are three types of hallucinations. There's auditory hallucinations, where you hear things that other people can't hear. There are visual hallucinations, where you see things that other people can't see. And then tactile, you feel like things are crawling on your skin. And delusions are also a part of psychosis. There's what we call grandiose delusions. First off, a delusion is when you believe something is true, in spite of all the evidence that it's not true. One of your residents leaves the residence and it's 100 degrees below zero in January. And he goes outside with no shirt, no shoes, no hat, swears that it's July. That's the delusion. All the evidence indicates it's January. It's cold out. He says, nope, it's summer. They're grandiose illusions. Like that resident of yours who believes that he can fly. So he goes on top of the tallest building in New York City and tries to fly, right? There's delusions of persecution where you think people are trying to hurt you. They found in England that CBD, when extrapolated from marijuana, can help them manage psychiatric symptoms more effectively than lots of psych medicine without the side effects. Alcohol used to medicate the grief caused by mental illness. Years ago, I worked in a shelter, and our clients had severe mental illness. It was one of our clients they called a cheerleader. Every night at 3 o'clock in the morning, she would put on a cheerleading outfit, pick up some pom-poms, and she would start to cheer loud. And she would wake up the other 24 clients that were asleep. She would also wake up the staff that would sleep on the midnight shift. I don't care what they say, they sleep too. It's impossible to stay up all night if you're used to sleeping during the day. The staff would go in the cheerleader's room. Then she would start to cry. Then the counselor would call her psychiatrist at 3 o'clock in the morning. The psychiatrist would say, let's increase her medication. So one day, I had a conversation with the cheerleader. I said, will you tell me your story? She was a graduate of a Chicago public school. She was the number one student, the valedictorian of her high school graduating class. She was also a captain of the school cheerleading team. She was a star. Valedictorian, captain of the cheerleading team. She went from a Chicago public school to UCLA in California on an academic and cheerleading scholarship at age 18. At age 19, she started hearing voices. Schizophrenia set in. She started experiencing hallucinations. Age 20, she's in our shelter, homeless. I figured it out. When a cheerleader would cry every night, she was grieving. What she was grieving was the life that she had before schizophrenia set in. The psychiatrist would always say, let's increase her medication. There's not a pill in the world that can treat grief. But what she would do to deal with her grief or depression is she'd drink alcohol. Drugs used to avoid the side effects of psychiatric medication. I can't even see you, and I promise you this. Over half of you all have been prescribed the medication where the side effects were worse than the benefit, and you stopped taking it. In fact, some of you all still have some pills in your medicine cabinet right now. You've had them there since 1963 because it just didn't work. Yes or no? You can put your response in chat. Have you ever been prescribed a pill by a doctor where the side effects are worse than the benefits? Just yes or no? I want to make sure I'm not the only one that's been prescribed pills like that. Side effects are worse than the benefits. Anybody respond there, Nikki?
Yes, they are agreeing
Oh,
with you, and I can
oh
concur
my
as well.
goodness.
Yes.
Oh my goodness. Is it cancer that kills you or chemotherapy? Oh, yes, yes, yes. All right. So we had a client years ago. And before bipolar disorder set in, she was on par to become like a supermodel. And I believe she was going to be a supermodel because when we would walk to therapy appointments with her, cars would come to a screeching halt. Buses would almost run in the back of cars looking at her. And she was prescribed the medicine for bipolar disorder. The side effects is that it gave her constipation and diarrhea, both. Talk about a medicine from hell, constipation and diarrhea, and it made her really thirsty. So she drank a lot of liquid to quench her thirst. And the liquid she was drinking, it put 25 pounds on her. Oh my God, I don't look like a supermodel anymore. And then it made her walk stiff, the medication. She threw away that medicine and started snorting cocaine. She said, after all, cocaine makes me lose weight. Alcohol minimizing the effectiveness of medicine, increasing the risk of overdose and suicide. Have you noticed that, first off, the organ in the body, when people drink alcohol and metabolize the alcohol, is the liver breaks down alcohol, 1 drink per hour. The liver also breaks down medicine and sends the therapeutic benefits of the medicine through your system. Now, a person is drinking alcohol and also taking psychiatric medication. If the liver has a choice between metabolizing the alcohol or the pills, which will it choose first? Always the alcohol because it's a liquid. And it's easier to metabolize liquids than it is solids. So the medication may be building up in the system while the liver is breaking down the alcohol. Plus, am I the only one who's ever noticed this? Have you ever noticed that when people drink a lot of alcohol, especially beer, they urinate a lot? So some people going to the bathroom, flushing the alcohol out of their system, might also be losing the therapeutic benefits of the medicine. If it were not for the fact that when you drink alcohol, it controls the vomit response, you've seen people drink and throw up, they would overdose and die from too much alcohol poisoning. Then, of course, there's a large percentage of people who commit suicide because they're depressed while being under the influence of alcohol and other drugs. We're looking at how the two interact with each other. Drug use can exacerbate psychiatric symptoms. You're already paranoid, and then you snort cocaine, you become more paranoid, right? You already have some paranoia. Then you use methamphetamines and you're more paranoid, right? You're already anxious. You take drugs like Valium, Xanax, and Librium. The withdrawal symptom makes you more anxious. You're depressed. You drink alcohol, it makes you more depressed. And then, of course, we know of people who use drugs to medicate feelings of uselessness in society. Sam Cooke sung a song. Here are the lyrics. I'm not going to sing or you'll leave the webinar if you hear me sing. Here are the lyrics. Once I lived the life of a millionaire. Was spending my money, I didn't care. Was taking my friends out for a mighty good time. Man, we drank all that good gin, champagne, and wine. Just as soon as my money got low, I didn't have any friends and I had nowhere to go. That's what addiction is like. When people hit rock bottom, they have no friends, nowhere to go, right? They're isolated. Feelings of uselessness can set in. We also know that as mental illness progresses, people lose jobs, families have to drop out of school. Feelings of uselessness can set in. People often medicate that feeling with use of alcohol and other drugs. And of course, if you're high all the time, it becomes really difficult to follow mental health treatment regimens. All right, so people who suffer from mental illness often experience more serious symptoms when drug and alcohol are involved. 1 + 1 = 3. Both of those together, the symptoms can get more severe. More intrusive thoughts, more feelings of hopelessness, a lack of motivation, fear of being out in public places. The more the individual uses substances to cope with their symptoms, the greater risk of developing an addiction. Then, of course, there's so many symptoms that we look for to determine if somebody might have a co-occurring disorder, right? And when we see a cluster of these symptoms, like a change in mood, anger, especially if you think they're hungover after getting high in the evening, they report voices, never reported voices in the past, we begin to suspect a co-occurring disorder. Do a thorough evaluation. So there are 3 types of co-occurring disorders treatment. One is called sequential. The resident receives services for mental illness and substance use disorder services one at a time. January through March, they go through addictions treatment. They graduate. April through June, they go to mental health treatment in sequence one at a time. A second type of co-occurring disorders treatment is integrated. The resident receives the service for mental illness and substance use disorders in the same facility at the same time. Third is called concurrent. The resident receives services for mental illness and substance use disorders in 2 separate facilities at the same time. Here's how that works. Monday and Wednesday, they go for addictions treatment at one facility. Tuesday and Thursday, they go for mental health treatment at another facility. Question, let us chat. Of these 3 types of co-occurring disorders treatment, which of the 3 do you think is the least effective? Is it concurrent, integrated, or sequential? Which is the least effective out of the 3? I think you will check in, see what they're thinking.
Sequential. Okay.
Whoever said sequential is absolutely correct. You know why? Thank you, Nikki. You know why? Because when you're doing them one at a time, it's like you can forget about the other. You know what that'd be like? That would be like a resident in a nursing facility who has cancer and diabetes. And the doctor's treating them for the diabetes, but not the cancer. So there's a value in treating both. The problem with concurrent, that is, even though it's better than sequential, what if the 2 facilities have different philosophies on treatment that can contradict each other? The best is integrated. Let's spend a moment talking about the components of integrated treatment. Psychoeducation. I did something that I'm really proud of a bunch of years ago. You see, in every behavioral health facility, the most educated person is a psychiatrist. So I always thought the psychiatrists went to school too long and they knew too much to just disseminate medication. They know too much. So I convinced our #1 psychiatrist to come to our facility every week and do a 45-minute lecture with our patients on the biological, we call it psychoeducation, on the biological basis of mental illness, the fact that mental illness runs in families. It's not your fault. What happens in the brain when a person has mental illness, diagnosis and how they're made. This is the criteria for depression, the criteria for schizophrenia, medication. What medication does, how it interacts in the brain, etc. You know what we learned? More education they receive from the doctors about mental illness, more likely they were to take medication. You see, in the past, we never taught them anything about their illness. Just take this blue pill 3 times, take that red pill 3 times a day. And then we wondered why they didn't take their medication. Another component of integrated co-occurring disorders treatment is family psychoeducation. Family has a lot of questions, like what causes mental illness? Will she ever get better? What are the symptoms? What should I do if the symptoms return? How can I be most helpful? Or they ask that Forrest Gump question. Remember when Jenny said to Forrest, "This is your son, Forrest." First thing that Forrest asked, is he okay? Does he have the same condition? Can the kids get this condition, right? Then counseling. You know why? Because love is the most important ingredient in all of recovery. I'm thinking of Earvin Magic Johnson, the basketball player. 33 years ago, he was diagnosed with HIV. If you remember the year that Magic Johnson was diagnosed with HIV, medicine for HIV was so poor that people would get their diagnosis and die. Remember that? 3 years ago, Magic said, when Cookie told me that she loved me, and Cookie's his wife, and then she said she would not leave me, I know that I would survive this. You know the number one reason that people with mental illness wind up hospitalized again? Is because of a loss in a significant relationship. I had a client who was walking down the street, and one of his friends from high school was walking towards him and said, "My condolences." The client said, "What do you mean my condolences?" "Oh, I went to your mother's funeral last week." His siblings never told him that their mother died because of his schizophrenia. There's stigma against his schizophrenia. The friend told him. He went into grief, stopped taking his medication, started drinking to deal with the loss of his mother. Like that client of mine came back from Afghanistan. He'd been a war hero, ready to marry his fiance. He learned while he was in Afghanistan, his fiance got pregnant by his best friend. Now they're having a baby together. It was at that point that he barricaded himself in his room and started drinking heavily and wound up in the ER. Love is the most important ingredient. Psychoeducation involves connecting with the family. Intensive family case management is a component of integrated treatment, providing entitlements for the whole family. Social Security, public aid, food stamps, whatever they need, you help them with that too, because ultimately they can support your client better. Assertive community treatment. An evidence-based practice geared towards helping residents who are living in homelessness. So the team would go out in the community, often consisting of a social worker, a nurse, a peer, a case manager, and work with the resident in the community, maybe getting them placed in a nursing facility. The goal is to keep them out of the emergency room of a hospital, which is costly. Identification of goals and purpose in recovery. Here's the story. My father died, as I mentioned, smoking crack cocaine, May 29, 1986. A decade later, my youngest brother called me and said, "I have a drug problem." I said, "I know." He said, "I need help." I said, "I know." I put my brother in detox for 3 days. He called me on the third day. "I'm bored. Now what do I do?" I said, "Go to a meeting of Narcotics Anonymous." My brother attended his first NA meeting. He called me in tears. I said, "Why are you crying?" He said, "After the speaker spoke at the meeting, I looked at the speaker and I said, 'You spoke the truth. I was there. I remember you. You spoke the truth. I was there. I remember you.'" The speaker was a man who used to use drugs and sell drugs with my father when my brother was a little boy. "You spoke the truth. I was there. I remember you." The speaker said to my brother, "You don't know this, but as soon as your dad died smoking crack cocaine, I got into recovery." There's a famous saying that some people die so other people can live. He said, "You certainly don't know this. When I was out there selling drugs with your dad, he saved my life twice." He said, "So I often ask God, why did you save me?" And my brother said, "Maybe one of the reasons that God saved me is so that I can help you." He's talking about purpose and recovery. You know, one of the questions I ask all of my clients, what are your goals in recovery? Because when you have goals and purpose, it gives life hope and meaning, a reason to want to stabilize. Integrate with the resident center care plan is a part of integrated treatment. Integrated treatment for co-occurring disorders by collaborating with community behavioral health service providers. Medication management is a part of integrated co-occurring disorders treatment. Let's take a moment to talk about stage-based interventions. Two psychologists, Prochaska and DiClemente, identified what's called the 5 stages of change. That is how people change. The first stage is called the pre-contemplation stage. Person does not believe they have a problem that needs to change. I call this stage the clueless stage, the clueless stage. Isn't it true that when a human being has a problem, that often the whole world can see it before they can see it? I have a first cousin who always dates the wrong person. You ever met someone who always dates the wrong person? She took the wrong person to junior prom. I can always tell when she's in a bad relationship because her mother, my aunt, will call me and tell me she's in a bad relationship. 6 years ago, my uncle said, Mark, she's done it again. I said, what? She's gotten to a relationship with a loser. I said, did you meet him? I said, no, I saw a picture of him. I said, wait a minute. You looked at a photo, knew this guy was a loser. We met on that Thanksgiving. He was a loser. Now, the mother knew looking at a photo. It took the daughter 3 years to see what the mother saw. And then 3 more years in the relationship, always a gap between what we see and what we do. The second stage is called contemplation, which also goes by ambivalence. Person knows there's a problem with mental illness, addiction, or both. They just have mixed feelings about whether or not they want to change. In other words, client says, I want to stop smoking crack or using heroin. Every time I smoke crack, it feels like an orgasmic experience. And nothing makes me feel better than heroin. On the one hand, I want to stop. On the other hand, it makes me feel good. You know the ultimate ambivalence? Is when you hand the resident their psychiatric medication, and instead of swallowing it, they cheek it. They put it right here in their jaw. And they're saying to themselves, if I swallow this pill, I'm agreeing with the psychiatrist that I have schizophrenia. If I don't swallow the pill, I don't have mental illness. Ambivalence, mixed feelings. Third stage is readiness. The resident is ready to change, but they haven't done it yet. The fourth stage is action. The resident is changing. They may be taking medication for mental illness. They may be going to NA meetings. They're changing. And the fifth stage is maintenance. When a resident is in the maintenance stage, they have been in recovery for 6 months or longer. So here's the deal. Rarely is a resident who has a dual disorder in both stages at the same time. Some residents may be in pre-contemplation in terms of acknowledging having a mental illness. They get angry if you even mention the thought of it, right? They refuse to take medication. They're going to 12-step meetings every day and meeting with a therapist around their drug use. Or, right, they're taking medication for mental illness, but they refuse to stop getting high. Goal is not to help residents make a quantum leap from pre-contemplation to action or maintenance. It's baby steps. Baby steps. This is a marathon, not a sprint. As Scott Miller said, there's no such thing as a resistant client. There's no such thing as a resistant resident. Problem is that we have lots of helpers that struggle to accept people where they're at in terms of the stage of change they're in, right? Resistance occurs when I try to force you to be in a stage of change that you're not ready for yet. Then you resist. And I accept you where you're at. Then can we help to try to inch you along? So how do you support a resident with a co-occurring disorder? We want to make sure that we treat all residents with dignity and respect. Be patient, right? Sure, we have lots of patience. Get to know the resident, find out what brings them comfort. Long as they have it, find out if they have any specific triggers. People have triggers for both mental illness and addiction. You know, a big trigger for mental illness is isolation. My mother has mental illness. And you know when her symptoms come back? When she isolates. You know when people are more likely to relapse? When they isolate. For some people, the smell of marijuana is enough to make them want to smoke marijuana. By the way, this marijuana today is so strong, it's so strong. It's like about 40 times more potent than the marijuana your grandmother smoked. You're probably wondering how I know your grandmother smoked marijuana. Oh, I know, right? A trigger might be seeing somebody you used to get high with. A trigger might be anger and rage, right? Get to know them, right? Find out about their triggers. Keep in mind that anger and irritability may be a symptom of their condition. Ask residents how you can help. Maybe a change of environment might help. Help the resident plan for what they will do if they're not feeling well, rather than throw away their medication or go back into a bar and start drinking. Identify and partner with organizations within your community that are supportive of co-occurring disorders recovery. Listen, have empathy and patience. Here's a story. I have a friend named Greg Risberg. Greg Risberg is a speaker. He told me that one day a man called him at midnight and woke him up. And I said, are you the same Greg Risberg who taught fourth grade across the street from public housing 30 years ago? Say, yeah, that's me. I was a kid living in the public housing. We were poor. I was a student in your fourth grade class. You were my teacher. He said, I'm a decorated military man. In fact, I wouldn't be surprised if I wouldn't wind up achieving the rank of a Colin Powell. I was just calling to tell you that you really made a difference in my life. Greg said, what did I do? He said, every Friday he would stop teaching. He would sit the entire fourth grade class in a circle. He would have us to read the newspaper from cover to cover. In reading the newspaper from cover to cover, what I learned that there was more happening in the world than simply what was happening in public housing. So it made me curious about the world. I heard him graduate high school, joined the military. I went around the world twice, he said. But you did something that was more special than that. One day he invited the entire fourth grade class on a special field trip. He invited the entire class to your house. You asked everybody to bring a bag lunch to your house. And I looked in my refrigerator that night, and I saw that I had no food. When I made it to your house with no food, you went in your refrigerator and you fixed me a sandwich. He said, anyway, the reason I'm calling is because we still have a home in Chicago. And I'll be coming home next month. And I wanted to invite you over to my house so I could fix you a sandwich. It took him 30 years to see the fruits of his labor. Those of you who have residents that have co-occurring disorders, you're like a farmer that plants seeds, who may not see the fruits of your labor in the season that you plant the seed. And sometimes it takes many seasons to see the fruits of your labor. In mental health, they have an evidence-based practice called housing first. Before any recovery, housing first. That's what you're providing in nursing facilities. Housing first. Celebrate small victories. Incredible story of this man who went fishing. And on the dock where he went fishing, there was a snake that had a frog in its mouth. So you pulled the frog out of the snake's mouth, and the snake was slithering away in tears. The snake was crying. Feeling sorry for the snake, you reached inside of your jacket lapel. You gave the snake a shot of Jack Daniels whiskey. The next day you showed up to fish, and the snake greeted you at the dock. And this time he had two frogs in his mouth. What's the lesson? When a resident achieves a little bit, like I didn't drink today. I went to my first 12-step group meeting. I only smoked 2 cigarettes instead of 10. If you get genuinely excited about the small stuff, they achieve bigger stuff. Reduce stress. You can help by reducing stress. What I didn't share with you is the number one relapse trigger of all is stress. Have hope. Provide a sense of community. The opposite of addiction is not recovery. It's community. The opposite of mental health, of mental illness, is community. People get better in community. Make sure the organization's policies and procedures are aligned with your approach to addressing co-occurring disorders. Ensure that all staff receive training on co-occurring disorders treatment. Receive education about harm reduction. Here's the deal. You have lots of residents that are not ready to stop using drugs. Your job is to keep them alive. Tell you a couple things that you can do to help people keep people alive. Alcohol is no joke. A sure way a resident can wind up in the emergency room of a hospital is to take their psychiatric medication or their high blood pressure medication or any medication along with alcohol, and they can wind up in the ER, right? Did you know that in 70% of those cases where people die of an opioid overdose death, alcohol is in their body at the time of death? Did you know that residents who've been in your nursing facility for a while and haven't used any opiates for 30 days, and they go back to opiates, they're more likely to overdose and die? They have been away from it for a while because the tolerance has dropped and they think they need the same amount they always did. If the resident is not ready for recovery, and we make recommendations to try to save their life, we call it harm reduction. Encourage first person language. You're not an addict, you're not a schizophrenic. You are a person first with an addiction, a person with a substance use disorder, a person with schizophrenia. You're not the homeless. You are a person transitioning from homelessness. First person. Native Americans said if you want to love something, call it a flower. If you want to destroy it, call it a weed. An addict is someone who you arrest, put in prison. A crack baby is someone you take away from the mother. The child is prenatally exposed to crack cocaine. You help the mother care for the baby. Honor the resident's level of readiness to change. Honor multiple pathways of recovery. There's no one way that people recover. Some people get sober in the church. Some people mature out. They get sick and tired of being sick and tired. Some people almost overdose and die. That triggers their recovery. Then, of course, work with the Center of Excellence on additional training topics. So who has the first question? Usually people are a little nervous asking the first question. Who has the second question? We're ready.
Wonderful.
Okay, yes.
Yeah, so please ask your questions. All right, we have a comment. I love your trainings, Mark.
Thank you
in
so
depth,
much.
yes, well explained and very, very useful from many perspectives with so many powerful stories that tie directly into your trainings. Okay, that's one
Thank,
comment there.
thank you so much.
All right. One of the best trainings ever. Thank you.
Thank you.
All right. Let me ask Derek if we have any hands raised. If you do want to come off of mute, please use the hand option to be taken off of mute so that you can ask a question or share a comment if you like. Derek, do we have any hands raised?
Not at this time.
All
So
right.
in the 3 minutes I have, Nikki, if they have questions, right, you can send them to me. I'll respond right away. I want to share with them something in closing. Then I'll
All
turn it
right.
over to you, Nikki. All right.
Mark, while you're
Yes.
doing that, we're going to pull the poll up, right? I'll turn it over to our technical support so you all have some time to complete that poll while Mark shares something with you, okay? So here you go, Derek. You can put that poll up right now if you like.
Okay.
So I encourage all of you all, because I know your work is really challenging and difficult. You have a range of residents you work with dealing with a range of challenges. I encourage all of you all in this lifetime uh, to go to Vegas at least once, just to relax, right? What happens there stays there. I went 11 years in a row to Vegas. And yet by the fourth day, I can't wait to get home. Even Las Vegas, I want to get home, sleep in my own bed. So last time I'm in Las Vegas, Nevada, I'm at the airport. And the announcement came over the loudspeaker, your plane has been delayed. So I'm angry my plane is delayed. But while I'm waiting for the next plane, I played the slot machines at the airport in Las Vegas, Nevada. I won $1.7 million. $1.7 million. Just kidding. I don't even gamble. I'm like Sam Cooke. I don't like the odds. If I ever get my hands on the dollar again, I'm going to hold on to the Eagle Grins. My next stop was to a small town called Galena, Illinois. A small town, the opposite of Vegas. No roulette wheels, no traffic, just me and my thoughts, crickets and stars. I came back from that little town, relax and replenish, ready to take on the world. Norman Vincent Peale said that busy people like you will help a lot of people like you do. It's mandatory for you to spend at least 15 minutes alone each day just to replenish yourself. You have that much more to offer the world. You get centered every day because yours is the important work. Once a week, I ask you to walk through the world with your head held high. They're going to look at you with your head held high. They're going to look at her. She thinks she's God's gift to the world. Look at him. He thinks he's a gift to the world. You know what you are? You've been given the gift of empathy and compassion and patience and the gift of being able to help other people. And you are using those gifts to make the world a better place. Thank you for all that you do. The world cannot compensate you enough for your important work. Thank you so much.